surgeons to accepting our invitation. And we are waiting for your lecture impatiently. And thank you again.
Thank you for the invitation. Let me share my screen. I wish I could be there in person, and maybe someday we'll get to that. But for now, at least we can talk electronically. So what I'm going to talk about is the management of the bulbous nasal tip. And please interrupt and feel free to, if you have any questions, to stop me. Or if you can't hear me or something. But one of the interesting thing is, I think, I do facial plastic surgery. Maxillofacial surgeons we're both used to dealing with bones. This is almost all about soft tissue and the difficulties in dealing with soft tissue. So, just to give an outline of what we'll be talking about, because I understand it's late at night for you guys, and I appreciate you staying up. We'll talk about the anatomy of the tip and the support of the nasal tip, the causes of bulbous tip, how that can affect function, and what the needs are in treating the bulbous tip. And then we'll go into some specific treatments of the bulbous tip and perioperative and post-operative management. So it's not a terribly nice term to call a patient's nose bulbous, because it just refers to the fact that it's just round and big and fat and really not a very attractive nose. But when you really think about what the nose should like in an idealized form, you can break this down into the entire nose into a series of polygons. And when you specifically look at the tip, we're talking about really this interdomal triangle and then these domal triangles with a little bit of the infralobular polygon here that you should see very, very discrete areas of the tip. The facets really should shadow. These are really shadows, but this is what is highlighted here at the top. And this is a little bit of a newer nuanced view of the tip. The old tip was you have two tip dividing points, and they're not this wide. They're really at the domes of the lower lateral cartilages. You have a super tip break above, and you have where the double break is, where the columellar lobular angle is, and that should form that polygon. But really, it should draw the eye to the center of the tip. Okay. We talk about dorsal aesthetic lines running from the inner aspect of the superior orbital rim down symmetrically and smoothly down the sides of the nose. And if you're not careful, if you just sort of bring that down straight, what you will end up with is a very pinched looking nose. These are the same faces, but just with two different sets of lines. If this comes down all the way to the tip in a very straight way, it looks like a very constricted, narrow tip. The more aesthetic tip should have some flare at the tip, okay? But you don't want it too big, okay? Other aesthetics things, we look at the nasofrontal angle. We do want to see a super tip break. And most of the time when you look at a bulbous tip and you appreciate a bulbous tip, you're looking from the front. But on the side view, on the profile view, you lose the super tip break. And oftentimes you lose this double break here at the columella. And those are the things you see on a profile view. On a base view, the alar crease should be directly below the medial canthus. The height of the lobule should be about 1/3 of the total height of the nose from those alar creases up to the tip. And depending on what number you want to use, you can either say, well, it should be the lobule here should make up 3/4 of the width if you draw it from the alar crease. Okay, but if you draw it from the most lateral part of the ala, it's about 2/3. So you'll hear different numbers. It really depends on what your base of that denominator, what the denominator is in terms of that equation. Are you talking about measuring from alar crease to alar crease, or from widest part of the ala to widest part of the ala? So it's either 2/3 to 3/4 of the whole width should be tip. Now, bulbous is just a word. There's no specific anatomic correlate. It just means it's really round and amorphous. We can talk about a boxy tip, which tends to be very similar, but those tips usually have very sharp angulation at the dome of the lower lateral cartilage, as opposed to the more rounded tip. But we'll talk about the different forms of bulbous tip as we go along. So what are the causes, right? So, well, you can have, if you think of your natural lower lateral cartilage as intermediate crus, medial crus, lateral crus. You can have a wide angle of divergence, and that's this angle of divergence beginning at where the medial crura touch each other and breaking apart to go towards the dome. So if that really should be less than 30 degrees. If it's more than 30 degrees, you start to get a very rounded tip. Okay. You can also talk about the domal angles. These angles down at that actually are formed by the intermediate and lateral crura of each lower lateral cartilage. And again, there's no specific numbers about that, but as that widens, that's also going to round out your tip. You can also talk about the distance between the tip defining points, and that's really a surface marker, okay, where you see the definition of the tip, and those should be about 4 to 5 millimeters between tip defining points from the left and the right side. So they really should be pretty close together. You don't want to have a single tip defining point because that makes the nose look very pointy. You want to see a little bit of separation. That's the most aesthetic tip that you're going to get, okay? Other causes, you can just have too wide lower lateral cartilage, particularly the lateral crus. You can have malpositioned lateral crura, you can have poor medial support, and you can have convexity of these lateral crura. And we'll talk about those as we go along. Another really significant and difficult point in terms of the bulbous tip, particularly the post-operative, the revision rhinoplasty bulbous tip, is the skin soft tissue envelope, okay? People who have sebaceous skin are really, really difficult to treat to have a nice petite nose. People who develop a lot of post-operative fibrosis, whether that may just be their natural status or because there's a little excess bleeding or they're not taped down well enough post-operatively, that will thicken up the tip. And there are some patients who have subdermal and even intercrural fat in this space in between the domes. And we'll talk about that as we go along. So, here's an example. If you look at it from an embryologic standpoint, you don't have this nice defined tip. This is a baby who's got a Tessier 0 cleft. You see there's a separation right down the middle. When you really look at the nose, you can see how far apart these lower lateral cartilages are. There's this huge gap in between. And if you look at that nose, it's a bulbous tip. You've got this big separation here in the midline palate. So in addition to, and actually had a dehiscence, he had a dehiscence in the orbicularis. So in addition to resuturing the orbicularis, we brought this incision all the way up, did an open rhinoplasty approach, reformed the philtrum, but also got up into the tip, defatted a little bit, and sutured those cartilages closer together to have a more normal shape to his tip. So those are kind of all of the things wrapped up in one other than the fibrosis. If you look at the key anatomic points, again, you should have nice thin skin over the nasal tip. You shouldn't have any subdermal fat or scar. There should be support of this nasal tip complex. The shape should be reasonable. The orientation of the lateral crura should be at least 30 degrees. If you have an angle here less than 30 degrees between the midline dorsum and the long axis of the lateral crura, if that's smaller than that, that crura comes up. It gives a lot of bulk to the tip. You don't see the natural shadowing at the super tip, and it's also actually a very functionally non-productive shape. So that needs to be addressed as well. And again, when you really want to talk about thickness of skin, these are 3 different examples, all of patients who are having skin cancer removal. And you can see that this tip skin is actually fairly thin. This is sort of an intermediate. You can see there's a little bit of a sebaceous nature to this skin, okay? And this patient was an early rhinophyma. And you see how incredibly thick this skin is. So you can imagine, here's the cartilage down here. Here's the surface of the skin compared to cartilage here, right here, and here's the surface. You can imagine how difficult it's going to be to get a nice shape to this nose because of this skin. It's just going to form a very thick blanket that will not contour to your cartilage shape. This is a patient I did a revision on, and she just had this big, bulky, boxy, bulbous tip, and got the opera report. And frankly, according to the opera report, the prior surgeon did everything right. But what she did tell me after the fact is, I had a lot of bleeding afterwards, and my nose just never came down. It was just really swollen. And she must have developed some sort of hematoma in the tip and developed all this fibrosis. Here's the natural cartilage. and this is just completely covered with scar tissue. And so in a revision technique like that, what I do is I go down, I identify my cartilage just to know where I am, and then I'm going to try to come right off the dermis, okay? Just right along the dermis, isolate the scar tissue, and then strip it down, if I can do it that way. Subdermal fat oftentimes can be seen right in between the domes, not just on the undersurface of the tip skin, but in between the domes, and that has to be removed if you really want to contour the tip. It's typically seen with platy noses. Sub-Saharan Africans, East Asians, that are the classic examples, but you can see it in Caucasians as well. So it's just something to be aware of. And those same patients may also have the other associated features of a platy nose. Very, very wide. Okay, they may be wide lower lateral cartilages, but they're soft and they're weak and they're very floppy. And you really have to ask yourself, how much can I work with this weakened, thinned out cartilage? Okay, how much can I do with it? I can put all the sutures I want. I can do whatever I want, cut whatever I want. But is that going to support a nice, strong, tense tripod that will show through the skin? Okay, and they'll also be underprojected. So these are sort of a complex of things: thick skin, fat, weak cartilage, that and giving you an underprojected, round, broad tip. That's a really classic combination. So this is just a quick video of actually defatting the tip. And obviously, when we talk about defatting the tip, you have to be careful to preserve the subdermal plexus on the skin. So this is an open approach. Sometimes it's just fat that you can see just hanging off the dermis. And I'm feeling with my scissors to make sure I'm up against but not cutting into the dermis. And then once I defat that, and I'm really looking, you can see there's just a tiny little bit left, and that's okay. You don't want to get right down to the dermis. But you can see there's another layer of fascia that here you can just sort of grab and tease out. And this is going to make that skin that much more pliable and that much more flexible to be able to wrap around your tip complex, your tip cartilage complex. Okay. Okay, so we talked about that. But you typically see these in these platy noses. A lot of fat in between the cartilage, splayed cartilage, very weak cartilage. A lot of times it goes right up the dorsum. Okay. And then we have to look at the shape of the cartilage, the shape of the lower lateral cartilage. So if you have a wide lateral crus, it's going to give a lot of bulk. These are all the same patients. Okay, you're going to have just a lot of bulk. You don't have any definition here to the alar crease. Why? Because she's got a 14 millimeter wide lateral crural. Okay, that's really wide. She was Mediterranean background, and you know, this cartilage was actually fairly thick. It held the shape. It did not want to give us any shape, any suggestion of that crease. So that had to be resected. You also see here, very interesting, this very wide intermediate crus. So this did not come up sharply and then turn at a sharp angle. It was a very broad, rounded tip. So that had to be addressed as well. Those are also two very typical things you see in the leptorhine noses, but you can have them. You can have them in any nose. Here's an interesting one. This Semitic background. This guy really couldn't breathe. And you don't see it if you look casually at the nose. But what he had was his lateral crus recurved. So medial crus came up here. Here's the dome. You can see the lateral crus here, and it fades backwards. So he usually stops. But when you look in his nose, and I'm going to show you an overexposed picture. I want you to look right here. I'm going to show you an overexposed picture so you can see internally in that area. You see that there's all this soft tissue. And that's actually the continuation of the lateral crus. It's too curved. And that was falling into the airway, and that's going to give him a nasal obstruction. So that has to be supported. So that roundedness isn't just going to give this rounded bulbous tip. In his case, it actually continued to be rounded and gave him a nasal obstruction as well. I mentioned cephalically oriented lower lateral cartilages, and we'll talk about the nasal tip tripod in a minute. But you really want to see an angle between the midline and the long axis of your lateral crus of at least 30 degrees, if not more, okay? Because you want this lateral crus to be closer to the rim of your nostril. It doesn't have to be exactly at the rim. But you don't want it coming way up here and mostly overlapping your upper lateral cartilage, because what ends up happening is all this area here becomes unsupported if your lateral crura are up here. Phenotypically, what you see is this kind of a nose, bulbous from below, but he also has the so-called parenthesis nose, where the bulbousness just kind of continues all the way up or halfway up the side of the nose. It's not just, wow, he's got this really rounded tip down here. It continues all the way up. And intraoperatively, what you can see is here's a long axis of his nose, and here are these cephalically oriented lateral crura. And so this angle is, like 25 degrees. So what has to happen with these, you can imagine, if I just take a little bit of this cartilage off, if I take a cephalic strip, if I just do the knee-jerk response, I want a smaller tip, I'm going to take a small cephalic strip off, and I take cartilage off here, that's up here. That does nothing over here, okay, number one. Number two, he still has all of this tissue that's unsupported. I'm now weakening his lateral crus, okay, which means he's going to be a setup for even more nasal obstruction post-operatively. So in this case, what has to happen is that these lateral crura need to be dissected away from the underlying mucosa. You need to put a graft to stiffen this up, and then make another pocket to place this lateral crus, to bend that lateral crus so it's out here. You actually have to reposition that whole lateral crural complex out laterally. And what that does is when you move it over here, where is it not? It's no longer up here. So you're going to get the definition that you desire here, because this cartilage doesn't go up this way anymore. It goes this way. Okay, you have a more defined nasal tip. So we talked about tip defining points. You want them probably 4 to 10 millimeters. There's no perfect nose, right? Everybody's nose is a little bit different. It depends on the size of the face, and the width of the cheeks, and midfacial width. But somewhere between 4 and 10 millimeters apart is where you want your tip defining point. You want to allow for an isosceles triangle of the tip on a base view. Okay. If you have more separation of this, you get a more bulbous, rounded tip. But if you end up keeping this angle sharp here, okay, or here, but these separate more, you end up with a boxy tip. It's really just, it's a variant. Bulbous tip, boxy tips really are just variants of the same problem. So, I've talked a little bit about nasal obstruction already, but, again, what are those causes? That recurvature of the lateral crus that we saw, okay, and the lateral wall. Insufficient external nasal valve support if your lateral crus is too cephalically oriented. You can certainly get nasal obstruction if you have a ptotic bulbous tip, okay? And if you have that real soft lateral crura, it's just going to be flaccid. It's going to collapse in. So those all need to be addressed at the same time as you're addressing the aesthetics of the bulbous tip. So we'll go through a bunch of scenarios, but a couple things to think about before you start your case. Not every tip needs to be smaller. It just doesn't. You have to look at the face. And certainly not every tip needs to be the same. All right? I'm really trying to move away from this cookie cutter idea of everybody's got to have the same exact tip. So I'm going to do the same procedure on every single patient. Wider faces can tolerate wider nasal tips. As maxillofacial surgeons, you know this better than I do. Okay. Ask yourself, what about the projection? Projection tends to be an issue in bulbous tips, and the same thing with rotation. Okay. If that tip is too ptotic, you can make it smaller. It's still not going to look good, and those typically go together. Projection, rotation, and bulbosity may go together. So, our tip change is always necessary. This is a woman in her late 40s who came to me with this crooked nose, couldn't breathe. We reestablished breathing. She had this hump on her nose. She really didn't like that. She didn't care so much about her tip, but she was crooked, and this concavity in the middle wall accentuated how bulbous her nose was. Straightened her out, not perfect, right? but it's better. And she was very happy with this. So there's no reason that you have to reformat the entire nasal tip. Okay, still looks better. She was happy. No reason to do the same, tip on everybody. Here's a younger girl. Okay, very pretty girl. Really came in and said, "Well, I don't like this bump on my nose," and it wasn't that big. Okay, but there was a bump there, and she was a little under-rotated for her height. She was a small girl. But if you look at her base view, she's a little bit rounded. This would probably qualify for a bulbous tip. You look at her here, I don't think you really appreciate it. It's a little broad. It's a little amorphous. We talked about it. She didn't want it. We did a little bit of a transcartilaginous cephalic strip here, just a tiny bit to give her a little more definition. You can see a little bit better defined tip here versus here. But it's still pretty rounded. And she's happy with that. We reduced her bridge. We raised the tip up. We rotated a little bit. And she's very happy. She's beautiful girl before. We don't have to necessarily do too much. One thing that comes in, I always like to put that slide in there because she's a teenager. And it comes down to tretinoin and isotretinoin. And what do you do with that person who's got very, very thick sebaceous skin? And I struggled with this for a long time, and I still struggle with it. And tretinoin topical, you can use it before and after. Going to reduce that sebaceous gland hyperplasia you see in those real sebaceous skin patients. That may thin it out. If you keep them on it long enough, it may thin out that skin envelope, so you see a little bit more of your structure. Isotretinoin, I don't know what your experience is. I remember working with an oral surgeon, and I was a resident actually, and I assisted her. Patient had a Lafort 1, wanted the plates taken off, and the patient had been on Accutane, isotretinoin, had been off it for 6 months. We went back and sized it, and there was absolutely no bone healing at her Lafort 1 level. Absolutely no bone healing. It looked like she had never had any healing at all. It looked like it was a fresh post-op, and we left those plates on. So after that, I have a very, very, very significant respect for what isotretinoin can do. However, Roxana Cobo from Colombia has talked about using it for 4 to 6 months post-op in patients who are really, really thick-skinned, sebaceous patients. She's in Colombia. She's got patients who have very thick skin, and she's using it pretty successfully. She says she hasn't had any issues. I'm a coward. I've taken it a step back. I put my patients on who have thick skin. I put them on tretinoin until they get really flaky, and I put them on this for at least 6 weeks to 8 weeks ahead of surgery to try to calm that skin down. So this girl's got this big bulbous tip, but you know what? It's also sebaceous. There's a limitation to what I can do based on the skin. Let's go half a step up. Now let's talk about minor aesthetic changes. Young girl, 16, doesn't want a lot of changes to the tip. She had a bump on her nose. She really didn't like that. She didn't want much to the tip. I apologize, this is a blurry base view. But you can see she's pretty broad. And I said, okay, we're not going to do it. It's still going to be a little bit rounded. We did a transcartilaginous cephalic strip excision. We reduced the dorsum and did osteotomies. This girl actually didn't want much change, but she had really, and you can see this cartilage, how strong this cartilage is. It's pushing right up against the skin. You can imagine palpating this tip and saying, there's a lot of resiliency here. You can see how hard that is. So she had this hard cartilage, and I knew that if I just did the same procedure here and just did a transcartilaginous, just a little incremental excision, nothing would have happened for her because that cartilage was so much more firm in her than in her. And so what we did was we did an open rhinoplasty approach. I did do a cephalic strip excision. I put a transdermal suture in on either side and then an intradermal suture to bring her together. But I was careful about how much I was going to do because she didn't want a lot. We did a dorsal reduction, medial and lateral osteotomy. And here are these two girls. And so if you look at them, this girl's tip didn't change all that much. But, she was very happy with that. It just blended and fit her face. This girl, again, didn't change all that much. You see a little less here. It's a little bit narrower. You can see on a base view, it's a little more triangular, a little less trapezoidal. But I did vastly more on this patient than this patient. And because of how thick that cartilage was, I didn't get much more of a change. Okay, so it's the balancing act between what you're working with versus what you do. Okay, here's a woman who came in, didn't like her nose, getting married, wanted to have something done to it. She's crooked, she's bulbous, her tip is overprojected, she's got a dorsal hump, she's got a deep radix, she's got a clear external nasal valve collapse when she breathes in. This nostril just collapses right in. And so we're going to do, and she also had an internal nasal valve collapse as well. So, you know, this started to become increasingly more complex. So this was an open rhinoplasty approach, dorsal reduction, bilateral spreader grafts, a radix graft to raise her radix up. We did a very conservative cephalic strip excision. We did intradomal and transdomal sutures. I dropped her tip back by separating the medial crura from the maxillary crest to let that fall back down towards her face to deproject her. And then to reinforce this really, really weak lateral external nasal valve, we put lateral crural strut grafts underneath the lateral crura, tucked into precise pockets in the ala, and hinged over the piriform aperture to support her. And here you see again, not a huge change, a little bit smaller. You don't see these tip defining points out here, closer to here. She's not trapezoidal, she's triangular. The tip has been deprojected, dorsum has been deprojected, raised the radix, and she can breathe now. You can actually see into her airway. She doesn't have this collapse anymore. So again, important to consider these functional aspects of the rhinoplasty. And this is a little video of putting a lateral crural strut graft in to help support that lateral cruce. So sometimes we're saying it's a bulbous tip. Sometimes you have to make this stronger so that you can bend it into a triangular shape. So I'm hydrodissecting off with my local, hydrodissecting off, and now dissecting off the vestibular mucosa from the undersurface of the lateral crura. And that's going out laterally into the soft tissue. There you go. You can see it a little bit better. And now I'm getting over the edge of the piriform aperture. And I've already harvested some cartilage, narrow, thin little grafts. Once I have that pocket, now you can see it's right up over the piriform. Okay, once I have that pocket, I can put this cartilage graft right into it. Okay, and what I'm going to do is I'm going to suture that up to that lateral cruce. So that cartilage becomes part of the lateral cruce, and that's going to support it laterally. So again, you can imagine, what am I doing? I want this triangular shape to the tip. I've got this part out here that's flail. Well, I can't very well narrow the top part and leave this flail part. I need to support that, because this is what I have actually, right? I need to support this part that's flail so that I can then shape it this way. And it'll stay intact, and the ala will stay open. So that's a nice technique to help keep the lateral ala open. Here's another girl, crooked nose, bulbous tip, overprojected, medium skin thickness. Her dorsum's deviated. She's got a dorsal hump. Also has a low radix as well. So crushed cartilage radix graft, dorsal reduction. Okay, mostly cartilage, a little bit of the bone, but mostly cartilage. We put spreader grafts in. Okay, also for breathing, also to help me maintain this dorsal septum in the midline. Okay. A conservative cephalic strip, I left 8 millimeters of lateral cruce intact. Intradomal sutures, transdomal sutures, resutured the medial crura together after I loosened up and separated the feet of the medial crura from the maxillary crest so that the whole tip complex could sit down closer to the face. Okay, and then I didn't draw it in, but we did medial and lateral osteotomies here. Okay, and again, what do you see if you look on her base view? You see it more of a triangular tip. Okay, as opposed to this sort of rounded, boxy or bulbous tip, however you want to call it. You also see this really crooked septum going from left to right, that's been straightened out. Her tip is closer to her face. Overall, just a better profile. Okay. Bulbous tip, medium thickness, probably a little bit thicker skin, deviated nose, dorsal hump, not that different, right? So here, you know, she was not overprojected. She actually had a relatively acute nasolabial angle. We put some crushed cartilage at the premaxilla. She was deviated. I harvested nice long pieces of septal cartilage for spreader grafts to help me hold that dorsal septum in the midline. Did a dorsal reduction, medial and lateral osteotomies, cephalic strip, interdomal sutures. Okay. And here you see it. And again, is she, you know, she's a lot. It's interesting. On a base view, I would look at this and say, this isn't that much different. It's a little different. Certainly more triangular, a little different. But here, that you really see the difference. Okay, so that's got to tell me that her major changes are not down at the lower part of the tip. They're really at this upper part of the tip here. Okay, and she's got this nice, strong, defined nasal dorsum. Here's that other patient with the really sebaceous skin that I show you. Underprojected a little bit, thick skin, deviated nose again. I seem to get a lot of deviated noses, and obviously a big bulbous tip. So, you know, we did interdomal, transdomal sutures just to bring that tip complex in, dorsal reduction, medial, lateral osteotomies, and I put a columellar strut in because she was so underprojected and so weak. Okay, this is somebody who had fairly weak cartilage. Okay, so rather than just suturing the two medial crura together and saying, well, they'll reinforce each other for support, I put a piece of septal cartilage in between as a columellar strut to not to increase the projection, but just to strengthen what I was doing so that her own cartilage should be able to provide the same projection that she needed. Okay, you know, and this is her about a month later. She's still a little small, but you can already see a huge difference in terms of her tip. Okay, she's still red here. This is an early picture. She hasn't been back. She's a nurse at the hospital, and she got COVID, unfortunately, so I haven't seen her lately. But she's doing okay. But you see, you know, still on the retin-A, still on the isotretinoin. You can see how flaky her skin is. She didn't like me very much for that, but I think keeping those sebaceous glands dry are going to help me get the shape that I want. Okay. So here's a quick video just showing. Oh, quick time out of it. Oh, I'm sorry. I apologize. I don't know why this is not running. Sorry. So we'll have to skip that one. But essentially, let me go back. To put a columellar strut in is actually quite simple. What you're going to do is basically separate the medial crura. Okay, you go down close to, but not all the way to the maxillary spine. What you don't want to do is rest that columellar strut on the spine, because when they smile and the orbicularis pulls on the tip, that bottom end is going to snap and they'll hear a clicking. They don't like that. So you leave it floating a little bit high. What you can do, the way I normally put these in, I was going to show you, so sorry about that video, is that I usually cut these long enough so this is too long. It may be sticking up out here. And I can use that to do some other things to increase my projection if I need it. Okay, once I get that in. And if I don't need it, I basically just take an 11 blade, sharp 11 blade, and cut this off and keep it below the domes. Okay, but I'm just suturing that through both medial crura in at least 2 locations. It's actually a very simple thing to do. But the key is to not go all the way down to the nasal spine. That's not going. Sorry. Different patient, not that different a tip, but thinner skin, rounded. This is truly a bulbous tip. Deviated again. Dorsal reduction, okay. Spreader graft on one side, okay, on the concave side, just to try to even her out. Medial and lateral osteotomies, conservative cephalic strip, interdomal sutures, transdomal suture, suture the medial crura together, and then I also harvested enough cartilage to put a shield graft in. Now, if you read the Toriumi and Johnson, the classic textbook on open structure rhinoplasty, that came out over probably 25 years ago, pretty much every single patient they operated on, they would put a shield graft in. And the idea of a shield graft in a bulbous tip, particularly in someone who's got very thick skin, is that the cartilage that's underneath here, the native cartilage, is too rounded or too soft to really push into a thick skin envelope, okay? And you'll never really get the definition you want unless you put this non-anatomic graft, and you can see it projecting higher than the domes. It's supposed to project higher than the domes, okay, in this situation. And you suture that to your intermediate crura and your medial crura. You put that in place, and then you drape that skin back over. And that's going to push up into the skin and give a more firm cartilaginous structure so that the skin drapes appropriately over the tip cartilage framework. So here she is before and after. And I can tell you, without a shield graft, I would never have gotten this defined a nasal tip just using her own cartilage. It just never would have happened. Okay? Now, she's got medium to medium thick skin. You cannot use these in a thin skin person because that skin will just, if it's thin, it will drape right over that. And this was you'll hear people talk about, oh my God, shield grafts, that's so old, that's so 2000. That's all old fashioned to do that. But they'll talk about it because it was used in people with thin skin. The skin drapes over that, and it looks like a little tombstone. It looks like a little marker, a little milestone marker, pushing right through the skin because the skin is too thick. And I would agree, no matter how much you bevel that, no matter how much you blend it in, it will always, with thin skin, it will always wrap right around it. Even her skin, which is sort of medium, you can see, it's wrapping around that a little bit. But on the other hand, it gives a lot of strength to the cartilage framework underneath it, and you get more definition to the tip. So think medium to thick skin, you can use the shield graft. Thin skin, don't use it. It's too risky. Hopefully this looks like this works. This is just placing the shield graft. You want to generally shave down the edges, bevel the edges of the skin of the shield graft so that it's not a right angle. But you don't want to bevel too much. And I start up in the dome, just below the dome. I suture this on one side. I leave it a little bit loose. I then readjust it while that's being held in place. Usually my resident holds this, but they frankly don't. They rarely hold it in the place that I want. I tell them to leave it alone. But we basically set that up, leave it a little bit loose with enough play to put the other sutures in. Okay, and then I come and redo the first suture. But you see how it's above the domes. If you're doing this for a bulbous tip, this is coming above the domes. These 2 points, the ends of your shield graft, become your tip defining points. That's where your light reflexes are going to be, because this is sitting above the level of the domes, which are down here. Okay, not a lot, but enough. 2-3 millimeters. It's sitting up above it. So if you use this and you don't want additional projection, you have to deproject the tip and then gain a little more projection to use this. Okay. And just suture it down inferiorly. I use clear nylon sutures. That's the way I was trained. I think they're really non-reactive. I've rarely ever had a patient have a problem with that. When I switched hospitals, they couldn't get it, and they were giving me a clear Maxon or a clear polydioxanone suture, which are long-term but resorbable. And what I found was I had one patient I had to go back and operate on, tremendous amount of fibrosis. So I've gone back to just using clear nylons and non-reactive suture. So, here's another patient, bulbous, she's underprojected. She needs a little more projection. Medium skin, dorsal hump, a little bit turned, a little bit crooked. We did dorsal reduction, conservative cephalic strip, interdomal and transdomal sutures to try to sculpt this tip tripod to a more narrow point. Looked at it and said, she's still too rounded. This is still too soft. We put a shield graft in. We also use here columellar strut to help project that tip, okay, because she's underprojected. We're gaining projection with the use of a columellar strut and with the use of our shield graft. We're getting increased projection. And the lighting is terrible, but actually I was visiting another doctor and I saw her in the waiting room and I grabbed her and I said, I hadn't seen you in 8 years. This is an 8-year result. And you can see she went from this very bulbous, sort of sebaceous skin, nice narrow tip, projection's reasonable. We didn't rotate her too much, and the dorsum looks good, and she can breathe. And now instead of seeing this big bulbous tip all the way out to here, you're seeing the tip is really just located here. Here's a knock on the shield graft. This, I look at this and say, this infratip lobule hangs down too low. This comes down, just doesn't really see it here, but on the frontal view, you just see it coming down too low. And a lot of that is just from having this shield graft there. Okay, so it does add bulk. You have to be careful about that. Another patient, shield graft, dorsal reduction. She needs a lot. She needs rotation. She needs projection. Okay, and she needs definition because look how broad. You don't see anything. I mean, her bridge needs to be narrowed, but her tip is really, really bulbous. So I actually took a little bit more cartilage than I usually because this was pretty stiff cartilage. So I left 7 millimeters behind. Took a cephalic strip, dorsal reduction. Okay, and also with the shield graft, and also put some just particulate cartilage grafts in the premaxilla to open up the nasolabial angle. And you can see her here. We've increased her projection, definitely increased her rotation, given her a better profile. The shape is much better, still a little bit rounded, but much better. Okay. And again, when I look at this 3/4 view, she doesn't. She loves it. When I look at this 3/4 view, I see the shield graft. You can see that sharp edge. That's a knock on shield grafts. Okay. But what's it giving us? Look at the definition. I mean, just look at this definition. Much more defined, despite all that thick skin. Okay. Here we're getting a little more challenging. Very pretty girl, very little projection. Ptotic, underprojected, dorsal hump. You can see how thin her skin is. Look how thin her ala are. It's like paper. She's very fair, underprojected. She's really a tough call. And I think she's from like one of the wealthiest families in Nashville, Tennessee. So a friend of hers sent me in, and I said I better do the right thing. Friend referred her. There was a lot of pressure on this one. So I knew I couldn't use a shield graft in this patient because she had such thin skin. So what was I going to do? I definitely used a columellar strut. Okay, I definitely did morselize the dome. We did a lateral crural steel. Okay, so we're going to take some of the lateral crura and advance it and add it to the medial crura. So if instead of the dome being right here, I decided the dome is going to be here. That means this cartilage rather, has to straighten and stand up tall. We now have more projection. Okay, if we do that and we can hold that there, that means that instead of all of this being the lateral crus, it's only this. So what are we doing here? We are increasing our projection. We are decreasing our lateral crus. So if you think of this in the nasal tripod concept, with 2 lateral crura being each separate legs of that tripod, and these two, or this central complex being the third leg, we're going to make this leg taller, these legs shorter. Not only are we going to project, but we're also going to rotate. Exactly what she needed. She needed rotation, and she needed projection. She had, reasonably strong cartilage. I had to morselize this cartilage to get it to bend. She did not, once we rotated and projected her tip, she didn't need that much dorsal reduction. We did a little dorsal reduction, medial and lateral osteotomies. And there she is. And you look at her tip and you say, wow, there's a huge difference in terms of the tip width. You can see it here. Okay, she doesn't have this hanging tip anymore. She doesn't have this really rounded bulbous tip. She's defined. She's got that nice dorsal aesthetic line with a little bit of a flare at the end. All right, she's projected, she's rotated, And what you don't see is you don't see any edges of a shield graft pushing through. Okay? So, you know, again, this is a thin-skinned person. You could think about a shield graft, but you should never use a shield graft in a thin-skinned person. It'll show through. So this is a quick video of a lateral crural steel. I know we're coming up on time. Just a few more. But what I'm doing is I've marked the natural domes, and I dissected free the mucosa from the undersurface of the cartilage. Now I'm marking where I want my new domes to be. And I've dissected equidistant on both sides of that. And I'm going to put a mattress suture in to fold that cartilage so that instead of the dome here, where it used to be, this piece, the dome is now part of the medial crural. The new dome is up here. This used to be out here. Okay? And that's what's given us that lift, and we've also rotated her back. Okay. Whoop. Hold on a second. Let's go back. Go forward. There we go. Okay. So now you've got a woman who's got a bulbous nasal tip. She's also underprojected. She's underrotated. She's got thick skin. She's got deep radix. Okay? So we throw everything in there. Okay? She's got thick skin. We have to really get something in there to push against that thick skin. So here's crushed cartilage radix graft. We do a very, very minimal dorsal reduction, just a little rasping at the dorsum and a little shave of cartilage right below it. We're going to do a conservative cephalic strip. We're going to do this lateral crural steel, okay, to increase her projection. We're going to do an intradermal suture to bring the tip together. And then on top of all of that, we're going to put a shield graft on top of that to push into this thick skin. And here you see her afterwards. She doesn't have this really amorphous rounded tip. She's got a nice defined tip. Not amorphous, triangular shaped tip. Look at the nostrils. They're oval instead of round. Her profile is actually pretty good, right? And all of that is because we've elevated and we've projected her. I think most of the projection we got was from the columellar strut and the lateral crural steel. I think the definition that we got is all, not all, but mostly from the shield graft. So this is a shield graft, and I think in the right circumstances, shield grafts can work really, really well. Okay, this is, I think, the last presentation. So bulbous tip, she is Chilean. Bulbous tip, she's underprojected, she's underrotated, she's got really crummy support to her nasal tip. If you push on it, you can imagine just touching this tip and the whole thing's just going to flatten down. Okay, she's got a really weak tip support. She's got a dorsal hump. So what do we do? And she's got thick skin, right? She's got this real thick skin. So we're going to increase her projection with columellar. Well, we thought about a columellar strut, but instead, what we decided to do is because she had such a short septum, and we really needed definition, we're going to add a septal extension graft, and that's what you're seeing here, okay? And that's what you're seeing here. So this is a piece of septum that we harvested. And if you can imagine, if it went right here and just stayed between the medial crural, it's, you know, if it was right, stayed right here, it's columellar strut. But we're going to suture it onto the caudal septum. We're going to suture it down to the anterior nasal spine. And we're actually going to have it project up beyond the natural profile. So we're going to use this to gain some projection, okay? So we've got this piece, and I'll show you in a second. But you can imagine, it's not that well supported unless you suture it down here. You put a couple of sutures in here, okay? And this caudal part will come in between the medial crural, so you're keeping it rigidly fixed, okay? So in addition to that, we're going to use that. We're going to do a lateral crural steel. I'm sorry, we're going to do an intradermal suture and actually then suture that new dome. Now, right up here, we're going to suture it all the way up to the most projecting part of the septal extension graft. You really got to hanging it really at the top of that septal extension graft. Oh, we have a video over here. Yeah, okay. Let me go back to that. So here's a before and after, and you can see what have we done. We've got a lot more definition, okay, without shield graft, but we've really increased her projection of her tip, right? There was nothing here. This is where she needed some support, and we gave her that with the lateral curl, with the septal extension graft, okay? We've then really tightly sutured the domes intradomally and then sutured them up to the caudal extension graft. So that really, really pulls it immediately. And what ends up happening is instead of having this sort of broad amorphous thing here, or just suturing, doing a transdomal suture, you know, is going to get it tighter, but it's not going to get this tight. We've actually pulled it all the way up here. Because when we sutured, it was down here. Then we sutured medial crura to lateral crura, it's down here. We actually pulled it all the way up here with another suture, which then puts the lateral crura on tension. This is called lateral crural tensioning. So for somebody who's got a weak ala, now it's tighter. It's not as flail. It's not going to flutter as much. So we've got aesthetics and we've got function all wrapped in one. So this is just a quick video on lateral crural tensioning technique. So what you'll see is it's just a still. You'll see the dorsal septum here. Okay. Here's the septal extension graft. I've sutured it together. It goes beyond that, and I've got extended spreader grafts that are sutured to the septum, and in between the septum and the upper lateral cartilages, they're making a sandwich. So you see how this is. You can't really see how far. It does extend about 7 or 8 millimeters caudal to the caudal septum. There you can see how far out it goes. Okay, so we're extending the septum. But you can see as I'm suturing this, it's still kind of flail. You really need to make sure you secure this tightly. So we've sutured it to the septum. We've sutured it to these extended spreader grafts. We're now tightening the suture of the extended spreader grafts to the septum. This is going to be, unfortunately, one of the drawbacks is it's a fairly rigid tip. It's fairly stiff. And as you see me tighten this, you can see, oh yeah, that really is. Okay. So now we're going to put these transdomal sutures in to narrow this domal angle. Okay. Later on, we'll put a suture, not in this case, but in other cases, when we don't use this, we can put a suture at the cephalic margin from side to side to get a better defined super tip. We're doing this to both sides to get these. See how tight this is here. This angle is no more how broad this is. This is nice and tight, this angle. And then we're going to take these and suture them up to the septal extension graft. You see, I have to pull a little bit to get this to come up. And yes, is this whole central component very wide? It is. That's why this has to be so tight, and it gives you a nice defined tip. Okay. So other things that you can try for bulbosity, you can section the lateral crus. Okay, you can, if you have a really, really thick cartilage and it's just very, very rounded, it's very convex. You can do a cephalic strip within reason. If that still doesn't flatten it out, you can actually cut through the lateral crus and do a lateral crural overlay. It's going to break that spring of that rounded cartilage. It's going to change that rounded spring to two pieces that are a little bit flatter. Obviously, you have to resuture these, and it's going to shorten this lateral segment. That's going to give you some rotation. You have to be aware of that as well. This is the lateral crural repositioning procedure I was talking about. If you've got these obliquely oriented lateral crura, if there's less than a 30-degree angle between the dorsum and the long axis of the crura, you actually have to dissect these out. You put a graft, a firmer cartilage underneath. Okay, you can use ear cartilage, you can use septal cartilage. And then you basically tunnel it into a precise pocket that goes out to the piriform, and you tuck that in. But you're doing it at a different angle. It's not going obliquely anymore. It's going more laterally. Okay, so that's how you deal with lateral crural malposition. Other things that you can try to manage a weak or a convex crus, you can, if it's just flailing in, you can stiffen it up. You can take a cephalic strip, take that piece that you would normally excise, and make a pocket underneath, between the vestibular mucosa and the lateral crus, and tuck that extra cartilage inside and suture that together as a sandwich to stiffen up that cartilage. You can do a lateral crural spanning suture across the lateral crural. Pull that in. The tighter you pull, the more that's going to pull in if you still have some bulbosity. The lateral crural strut graft is a schematic of it. You can imagine if this was really overly convex, you can flatten that piece of lateral crus out with even a non-articulating lateral crural strut graft. If it's if it's really, you don't have to worry about this. Oops, sorry, you don't have to worry about this. Look at this. If this was really rounded, you can put a mattress suture. You dissect the vestibular mucosa from the undersurface, and you put a mattress suture with the long strands running externally, so that when you tighten that, that's going to flatten out that extra concavity. It's just going to flatten it out because you have these sutures that are going up and over. So when you tighten it internally, it's going to pull down. It's going to flatten that crus. So that's a modest little touch-up technique. So just to recap, a lot of things you can do, really hard. A lot of things that could be going wrong with the bulbous tip. Sebaceous skin, prior surgery are all really tough. You're going to have thick skin. You want to manage that. We didn't really talk about fluorouracil. I mostly use intralesional Kenalog or triamcinolone acetate, 10 to 40 milligrams per cc. I'll use 0.2 or anywhere between 0.05 and 0.25 cc's in the specific areas I feel that there's excessive fibrosis, that I'm not getting the definition I want. So I'll inject it very often in the alar crease area if post-operative I think there's too much scar tissue and it's still too rounded. You can do a lateral crural strut or lateral crural tensioning in the setting of sebaceous skin, because you know that skin is still going to be thick and you're still going to need to give as much structure and as much form as possible to the underlying cartilage. Columellar strut, columellar shield graft. Again, sebaceous skin is great because it's going to hide any irregularities. You just need limited contouring. A cephalic strip is great, but it's going to give you limited contouring like I showed you in those early cases. Underprojected tips, the lateral crural strut, lateral crural tensioning, columellar strut, shield graft are kind of my go-to procedures. Same thing for an underrotated tip. You may add in a cephalic strip with that. The malpositioned lateral crus, really you have to just reposition it, okay? And if it's excessively convex, then sutures and the turn-in flap, and sometimes the cephalic strip will help you as well. So, post-operative care, I have them on those sebaceous patients on topical tretinoin. It's been reported in the literature to use oral isotretinoin, but be cautious about that in wound healing. I now always give a short course of oral steroids. I was trained to do that, and then I said, well, there's risks. There's risks to giving even healthy patients corticosteroid for a short period of time, and I stopped doing it. And then one of my patients came back, and she said, did you get my message? And I said, no, I didn't get your message. I haven't seen you in 2 weeks. She said, right, because right afterwards I had shrimp, and I had an anaphylactic reaction to shrimp. And I said, what did they do? And I said, did they give you steroids? And she said, yeah. And I said, well, it's 2 weeks. Your nose looks great. And she started laughing. She goes, that's what I thought. And so I think putting her on, the short course of oral steroids really does help. And so I've gone back to giving all my patients a 5 to 7 day taper of corticosteroids. I tape the tip tightly for 2 weeks. Okay, so they'll come back to see me at 1 week. I'll take the tape off. I take any cast off, and then I retape them, and I'm gluing them down, and I'm taping them tightly for the first 2 weeks to make sure I don't get any excessive fibrosis. The triamcinolone 5-fluorouracil now, I've started to use it. It seems to be a little more potent than the triamcinolone, but it's a chemotherapy drug, and I have to tell patients that, and a lot of patients don't like that. And close follow-up. You can't just assume these people are all going to heal exactly the way you want to, particularly if they're sebaceous skin patients. So in summary, the sebaceous nose, or sorry, the bulbous tip is a really, really challenging rhinoplasty. But if you follow up on it, you can make a tremendous difference in these people's lives, because that's something that they have hated for probably their entire life. And if you can make that, if you can define what they want, you can give them what they want, they are some of my happiest patients. So with that, I will stop. I will thank you here from New York. I thank you for the invitation and your attention.
Thank you, dear Professor. Excellent presentation. For those who are attending this course, if they have a question, they can unmute the mic and ask a question. And some of them I have seen they joined very late. Send them the YouTube link later on to them. Dear Professor, some of the bulbous cases, they have a dimple on the nose. How you overcome this dimple?
The dimple in the center?
Yes, on the lateral of the area, they have a dimple. Most of them, those bulbous nose, they have these characteristics.
Yeah.
How you are overcome this?
Again, most of these cases, almost all of these cases, unless they don't want significant change, even if they want modest to moderate changes, I'm going to do an open rhinoplasty approach. And then you can really get a sense of what the problem is. In my experience, the most common problem is that excessive curvature of the lateral crus. And so a lateral crural strut graft that lies underneath the lateral crus can straighten that out. So you're getting this dimple out laterally where the cartilage is coming in. They're getting basically have this bulbous tip and then all of a sudden a drop off. If you can reshape that cartilage so that it doesn't curve as much by putting a strut graft, lateral crural strut graft underneath that, between the vestibular mucosa and the lateral crus, that usually takes care of it.
Yes. We don't have your voice, sir. Dear Professor, we don't have your voice.
Me?
Yes, now it's okay.
Okay. Did you hear my explanation?
Yes, yes,
Okay.
I have got. I have seen one of your cases. Do you have used turbinate perforated bone for stabilization of the segment septal extension graft?
I haven't used turbinate bone. No, I've not done that. Generally speaking, I've become a lot more willing to take rib cartilage, and most people, if they're primary, I can get enough septal cartilage to do just about anything I want, with the exception of sub-Saharan Africans and East Asians or Caribbeans with a lot of sub-Saharan African ancestry, because the septal cartilage tends to be very short. But most Caucasians, I can get enough cartilage from the septum. If they're revisions, I used to, take conchal bulb cartilage from both sides to try to avoid a rib graft, and I'm getting away from that now, because for me to harvest a piece of rib, I can do that in the time it takes me to harvest 2 ears. So it's a single site, and the cartilage that you get from a rib in anybody under the age of about 45, 50 is far superior to the conchal cartilage. Conchal cartilage is curved, it's thin, it's not terribly strong, and up until 45, 50, the rib cartilage really is pretty flexible. It's not that ossified, and it's easy to work with. So, with that, I can take, I can get the septal extension graft the size I want.
Yes, thank you. And my last question, I don't know whether I'm correct or not. I wanted to know what is the difference between the tongue and groove graft and the extension septal graft?
So, the tongue and groove technique really is for stability. So you can do it for one of two reasons. You can either stabilize the medial crura and the tip by suturing those back to the caudal septum, right? So the septum is the groove, I guess that's the groove, or the groove you make is in between the medial crura, okay? And then the tongue is the septum that comes in, okay? So you recess the medial crura back up to the caudal septum. And that you can project the tip, you can deproject the tip, or you can just stabilize it. Another reason to use that is if you have a severe caudal septal deviation and you don't want to do anything to the tip, you can dissect a groove in between the medial crura. You can do this through the inside of the nose, through a hemitransfixion incision. You can dissect that out, and I do that for some mild deviations of the caudal septum. If the cartilage is soft enough to bend, I'll make a little pocket in between the left and right medial crura. Okay, my cartilage may be off to the side. I'll put a suture through that caudal septum, okay, and put it right in between the cartilage. So that stabilizes it, okay? If you're putting extra cartilage in between the medial crura, that's a columellar strut.
Thank you.
Okay.
Dr. Parhiz, if you have.
Okay, thank you, Professor. Very practical, very useful the presentation. Thank you so much again. I'm waiting for my colleagues. If there is any other questions.
Feel free to send me.
Yeah.
Hello, Dr. Parhiz, and thank you very much, Dr. Sclafani. Can I have a question?
Can you repeat, please?
Dr. Parhiz, can I have a question? Dr.
Yes,
Sclafani.
Professor Hashemi.
Yes,
Professor Hashemi, please ask your question.
Yes.
Thank you.
Yes, Dr. Sclafani, thank you very much. I want to know, do you use injection of triamcinolone in bulbous nose? My experience is that 6 months after removing the splint, maybe I used triamcinolone injection, and 50% I took the good result. But I want your your experience about this injection, and how do you use? How many doses? How many interval? Thank you very much.
That's a great question. Thank you, Dr. Hashemi. It's a really good question. I have become more and more liberal in terms of my use of triamcinolone. So I tell every patient, and in particular, I had a revision patient last week, and if it's a sebaceous skin patient, I tell them, I probably won't do anything before 6 weeks, but the revision patient, I talked to her, I haven't even taken her splint off. She said, are you going to give me an injection of steroids tomorrow? And I said, no, that's not we're going to let you heal a little bit. But by 6 weeks, I can get a sense of how much the swelling has come down, and I can really assess if I'm going to need it. In a sebaceous patient, I tell them it's almost certain that I'm going to give them an injection at 6 weeks. In a revision patient, I tell them it's pretty much guaranteed I will give them an injection at 6 weeks. I tell them, number one, you know what? Everybody's a little bit different, but the average person doesn't see any changes for the first 2 weeks. The third week they notice changes. It may be something as subtle as softening. And then the fourth week, there's not that much changes. The changes subside, and I want to see you back in a month. Once I start my first injection, I'm seeing them at 4 weeks after every injection. And I tell them, as long as it's doing what it's supposed to do, I keep injecting. And there are patients I've injected 7 or 8 times over the course of the first year. The one little trick that if it turns out that, it's too stiff, there's too much scar tissue, I'm not able to get very much medication, and hence I'm not able to get much of a result, I will use a higher concentration of triamcinolone. And, I'll inject it to the point where I don't get the benefit. I'm making sure that I get below the dermis, so I'm not going to get any skin atrophy. And as long as you do that, it's safe to use those. There's no problem with any cumulative effects. And as long as you're progressing, I use that as almost a sculpting technique. There are certain areas that may look better with a little bit of fibrosis. I'm not going to necessarily try to get rid of all the fibrosis and all the scar tissue. I'm going to inject the the super tip area. I'm going to inject the superalar crease to try to shape the nose. And as long as I'm getting the results that I want, I'll keep going. And you know, the patients become part of it. The one last thing I'll mention, since you mentioned 6 months, I have seen a couple of patients who, you know, it seems like it's great. It seems like we got just about what we wanted. And I just say, great, you're done. And they come back 3 or 4 months later saying, you know, it seems to have regressed. Seems like it popped back again. It grew back. And sure enough, sometimes that happens. And if that happens, I go back to the steroid injections. And instead of saying, hey, you know what, we're done, we got you where you want to be, I'll have them come back instead of 4 weeks. I'll have them come back at 8 weeks and maybe put a tiny little dose in, another tiny dose of steroid in just to maintain it. And then I'll have them come back instead of 2 months, I'll have them come back at 3 months and just sort of slowly back off the triamcinolone, and those usually stabilize. But it can be really tricky. I mean, it's really crazy. And patients look at me like, why is this happening? And, you know, the answer is, frankly, it's your nose. It's not me. It's your physiology. Most people don't do that, but sometimes people do. And you have to let them know, look, this is not me. We're trying to accommodate what your physiology is doing. And there are ways to do that. So it's not like an all or nothing. It's not a 1, 2, or 3 injection thing. If I get all the effect I want from a single injection, then I stop. And I tell patients, I am not trying to replicate nature. I am not trying to best nature. I'm trying to just get you to an even point where I think you should be. If I think your swelling and your fullness is going down slower than it should, then we're going to do the steroids. If I get you back to a point where you're supposed to, if we're at 3 months and it looks like I think you're supposed to look at 3 months, even if I just did an injection, I'm not going to do another injection. I'm not trying to hurry nature. I'm just trying to make nature do what it's supposed to do.
Thank you very much. Thanks a lot.
Thank you.
Dear Dr. Anthony, is it the Pitanghi ligament? Is this essential to bring it back in? Not necessary.
I don't do it. I don't think so. I think, and again, the ligament, no, but I'm suturing the domes together. If you do an endonasal delivery technique, you by definition are separating Pitanghi's ligament, right? And if you separate Pitanghi's ligament and then push everything back and expect that to heal, it's not going to heal the way you want it to. If you're doing an open rhinoplasty and you've done all this work to the tip, you got to sew those back together. And if you've got a bulbous tip, absolutely you're recreating it essentially. The ligament itself, there's some accessory ligaments that actually go to the skin that was just described a couple of months ago in a paper. They're saying, well, you know, we should try to preserve that. I don't think you necessarily need to preserve Pitanghi's ligament, but I think you do need to suture that down. I don't, and I know some people who will put a suture from the dermis at the super tip to define the super tip. That makes me nervous. I'm conservative. That makes me nervous. I would rather get rid of any soft tissue. And I'll tape, believe me, I tape those patients really, really tightly. And they don't like me because they can't breathe because the tape is around their nose. That's just how it has to be.
Yeah, thank you so much. Any one of other colleagues, if they have a question, they can unmute the mic and ask a question from Dr. Anthony, please. Otherwise, we don't want to take his time a lot.
Thank you for staying with me this late.
No, thank you so much. How is the corona there in USA?
Well,
in
USA
Iran is
terrible.
horrible.
New York, it's actually very low. I just heard the statistics that for our system, we have part of our hospital system here that you see is about 2,500 hospital beds. I think we have about 100 patients with corona, and I think there's only about 20 or less that are intubated. There's very little. There's actually very little in New York. It's very much controlled in New York.
Very lucky. You are very lucky.
Yeah. So
you are lucky. Our country is very bad.
Yeah. Everywhere. Is it everywhere?
Yes, everywhere. In England also today I heard a lot. Dr. Parhiz, do you want to speak anything? Dr. Parhiz?
What's your idea about election? Trump or Just
Dr.
one.
Hakimi is
I just want the election to be over. 1 week, and I'll be happy when it's over.
and next week, this time will be over.
Exactly. Exactly.
Yeah. Perfect.
Thank you, Professor. Very nice to have you here. And I hope this Corona time also finish and we can see you at Iran.
Absolutely.
Thank you so much.
Love to. Thank you very much.
Thank you so
everyone.
much again, Professor. Thank you.
so much. Thank you for your
Thank
attention.
you.
Okay.
Bye.
Bye-bye. Bye-bye. دکتر پریز کاری ندارین که انشالله